Top Med Talk.
Hello and welcome to Top Med Talk and our special series of podcasts on the coronavirus pandemic, in which we aim to keep you up to date and informed during these challenging and fast-moving times. I'm Joff, Lacey, and I'm delighted to be joined today by Dr. Kariem El-Boghdadly. Kariem is a consultant anaesthetist at Guy's and St Thomas's here in London, and amongst many of his clinical and research credentials, he is also the scientific officer for the UK's Difficult Airway Society, or DAS, as many of us will know it. Kariem, many thanks for joining the Top Med Talk team here today.
Pleasure. Thank you for having me.
So we've invited you to chat to us about a project you have spearheaded through your role with DAS, the Intubate Covid project. And this is a project that has at its very core the safety of healthcare professionals as it looks to scrutinise the risk posed to those involved in intubation and advanced airway management during the COVID crisis. So we thought it would be of particular interest to the large cohort of Top Med Talk listeners who are regularly involved in such procedures. Now, the premise for the Intubate Covid project relates to evidence not only from the current COVID pandemic, but also from the SARS outbreak back in 2002, 2003. So would you mind explaining just in a bit more detail the need for this project?
I think what you highlighted there is absolutely spot on, in that we know that tracheal intubation and airway management is thought to be a really high-risk aerosol-generating procedure. Now, healthcare workers in particular, when we look back at the SARS pandemic, they were disproportionately affected. In fact, in Toronto, nearly half of all those who contracted SARS were healthcare workers, which is a phenomenal number.
Yeah.
And then looking back at some of the evidence and the analyses, what we've seen is that we believe that the risk of a tracheal intubation being associated with conversion to a disease such as SARS is about 6 times greater than the normal healthcare worker or the normal procedure. So it's a procedure that's associated with a lot of risk to the operators. But we really don't know how high that risk is. And we really don't know whether what we're doing in terms of personal protection, in terms of actually performing the procedure, in terms of who's around, our proximity to the patient, where the procedure is being done, we really don't know what those risks are. And so on the back of the fact that actually the data from SARS seems very different, the virus seems very different to the SARS coronavirus, because that's why it's a separate entity. And that's why, we're all navigating our way through managing this condition and through managing this virus and this pandemic. So we really wanted to try and capture data. And really the focus here is the healthcare worker, not just the person who's intubating, but the assistants as well. So we're collecting data on the assistants who are exposed. And then the other thing just to bear in mind is the way we've built this project is it's obviously very dynamic and responsive, but we're also looking at tracheostomies now as well. So we're now starting to gather the information on tracheostomies, which is going to, we think, play a really, really important role in the management of these patients, because we're seeing more and more tracheostomies. Certainly at our institution, we've done about 50 tracheostomies for COVID patients so far. And this is going to be a theme moving forward as the pandemic shifts to the more chronic phase of management of these patients.
And can I ask, so you mentioned that some of the data from the SARS outbreak directly showed that intubation or aerosol generating procedures significantly increase your risk. Do we have that similar kind of data from the COVID outbreak at the moment?
So what we have is we have data that shows that healthcare workers are at a greater risk in that the proportion of healthcare workers that make up the total population of those that have contracted COVID is greater than that of the background population. Yeah. So we have that data. Certainly at some time point in the Italian outbreak, it was up to 10% of all of those with COVID were healthcare workers. Yeah. So those numbers are, of course, changing as background population exposure increases with time. But we can see that actually healthcare workers are at greater risk. And it really makes sense why. We're frontline. We're facing these patients who are at their sickest with the highest viral load and we're coming very close to them because we have to manage these patients. So it really does make sense, but we really don't know what that risk is, and we really don't know how effective all of our protective measures actually is.
Many people will say, well, of course, there's a higher or disproportionate risk of being a healthcare worker because, as you say, you are surrounded by the risk. But whether we are mitigating that risk as best we can is a totally different question.
Absolutely. And I think one of the things that we tried to consider was we wanted to be as granular as possible with regards to the PPE that we're using. So we're collecting data globally on the differences in PPE, and we don't know if we're going to get enough data necessarily to tell us that using a FFP2 versus using an FFP3 mask is associated with differences. We don't know that yet. We may or we may not, but we are trying to capture that. The other thing in terms of minimizing the risk of exposure is guidelines all around the world have been published for the management of these patients in terms of tracheal intubation, and there's consistency in recommendations for using things like a video laryngoscope because that allows you to minimize the time that it takes to successfully intubate the patient. It also allows you to be further away from the patient's face and therefore reducing the viral load exposure that you're obtaining. So we're trying to capture as much of that data that we think may have some form of impact on the risk of conversion to COVID.
And so if we can delve a little bit more then into the specifics of the project aim. So obviously, as you mentioned, you're wanting to capture healthcare workers' exposure to an intubation procedure and them developing COVID symptoms. And then you've touched on a few of them, but looking at the specific risk factors. So PPE obviously is a big factor. And so you're going to be looking at the variations or the specifics that the intubator and their assistants are wearing. And then you're also recording the kind of airway management involved. Is that correct? So different techniques used, or is it? Tell us more about how you're examining those risk factors.
So one of the things that we wanted to capture was the procedure itself and what you're doing for the procedure, because we think that the longer that it takes you to intubate, or the more challenging the intubation, or the more adjuncts that you need to assist and to facilitate tracheal intubation, the more time you're being exposed and the more likely you are going to be exposed. So we're collecting information on whether you used a video laryngoscope or a direct laryngoscope, whether you've done it with a flexible bronchoscope, for example, if you needed adjuvant, if you've done things like apneic oxygenation with high flow nasal oxygen. Now, this is really topical and everyone discusses, does high flow nasal oxygen lead to aerosol generation? We don't know. So perhaps it may not. So we're trying to see if, even if it does lead to aerosol generation, does it actually lead to any increased risk to airway managers, for example? Whether you use bag mask ventilation, we know that mask ventilation itself is an aerosol generating procedure. And so whether you did that during your tracheal intubation process. And of course, the number of attempts, we use that as a surrogate number in terms of telling us how long it might take. Of course, the time to intubation we discussed whether we would look at that, but I think that that's a really hard metric to capture because, I've intubated countless COVID patients now, and what I've seen is that one loses track of time very easily. So time to intubation is not a metric we're looking at, but how difficult the intubation is. For
those listening who want to get involved, what is the actual process involved in those that you want the data from? If I'm a healthcare worker now who will regularly come across intubating COVID patients, what do you want them to do and how do they do that? There's a couple of things to be clear on. Firstly, this isn't just for anaesthetists. Yes, absolutely. For ED physicians, we've got pre-hospital physicians that are reporting as well. We've got intensivists that are reporting as well. The other thing is it's not just for doctors. So we've got anaesthetist assistants and ODPs and nurses reporting as well. Now that we've expanded into the States, we've got lots of CRNAs that are reporting data. So it's for everyone. And it doesn't necessarily have to be used only if you're doing lots of procedures. Every single procedure counts. Every single procedure helps us understand baseline risk and baseline performance information. And literally all you do is you go to the website, which is
www.intubatecovid.org, one word, no hyphen, and you register. And what we're capturing is, when you register, we're capturing information on your background demographics. So who you are, where you work, your age, just so that we have an understanding of who's actually performing these intubations.
The demographics are an important part of your risk factor analysis, really, for those who go on to develop COVID.
Absolutely. And that's why we're capturing this information, really. We're capturing your gender, because there is some suggestion that males are disproportionately affected. We're capturing age as well. What's really interesting is the median age now is very, very consistent no matter where in the world you are for people who are actually registering and performing this. So it's really important for us to have an understanding of these demographics, because that tells us that each individual patient, each individual operator that's associated with the risk, is it the PPE that they're using, or is it just the fact that they are actually of a demographic that's likely to get sick from COVID?
And then, so once they've registered and logged on all the various details, the process is simply, after you've done an intubation, log back in and just in a matter of minutes, log all the various information that you're requiring.
Once you've registered, each intubation that you actually do, you log in again. You've got your own login details. It's all anonymized, so we don't share it with anyone or anything like this. You can register each intubation, and it takes about a minute. Literally, it takes about a minute for you to put in the intubation details. We try to keep it as quick and be as lean as possible with the data that we're capturing. And I've actually personally found that logging my intubations is kind of cathartic in a way. I mean, it's helping me look back and reflect on the process itself. But it does take about a minute to do, so it's super quick. And then once you've registered it, it goes into your logbook. So everyone gets their own logbook of COVID intubation on your login. So you can see all of the ones that you've done, which is useful in its own right, I think. Once a week, we're going to be sending you an email to tell us what's happened to you over the last week. So what we mean by that is, have you gotten symptoms of COVID? Have you self-isolated? Have you been admitted to hospital, or have you had no symptoms whatsoever from your COVID? Now, this is key. This is really the clincher that's going to tell us what's happened to people based on their exposure. So we've got the exposures, which is the airway episode, and we've got the outcome, which is the weekly follow-up. Now, of course, you don't have to wait to get the email that we send every Friday. You can log in and do it automatically, yourself. Just register onto your own account.
Are you going to be able to record the severity of the symptoms for these healthcare workers? Because one of the hypotheses relates to the potential high viral load that we're exposed to may precipitate a more severe reaction. Is that something you're going to be able to track?
Good question, Joff. I think it's hard to capture severity in a huge amount of depth.
Yeah,
with the way that we're delivering this. But what we are really capturing is every symptom that you may have. So we will be able to know what symptoms each individual operator has each week. And then the other thing that we'll be able to capture is if you have been admitted to hospital with it. So we've got the hospital admissions, we've got the symptoms that you have, and we've got the self-isolation.
Okay.
We give everyone an opportunity to write a comment. And we're going to be looking at each of these comments to write a comment on what's happened to them this week. So people have already described to us more detail on the symptoms that they've written, and we've seen that. So we've got a lot more information there. Analysis of that may be challenging, but we can definitely use that information to understand better and infer the severity probably of your COVID symptoms.
This has been set up under immense time pressure in record time, and you've been able to secure the endorsement of backing of all the major stakeholders. So where are you in terms of where you had hoped or expected to get in terms of number of registrants and records of intubations? What's your current status?
We have to work really, really quickly to get the project off the ground at the right time, because we knew that if we waited any longer, if we delayed for any reason, we would miss the boat in capturing this information, I think. And certainly if we had started it now, then we definitely would have missed the boat. So we got it set up in a couple of days, really.
Wow.
We trialed it for a couple of days. We got our approvals super quick. It was on a Thursday, I think, that we got started and put it all together. And by Monday, we were ready to go. And we launched it on the 23rd of March.
That's very impressive.
So we really believe that this is important for the safety of healthcare workers. So we just went for it. And the way that we designed it, of course, was it's an adaptable project. It's a service evaluation. It's gotten approval as a service evaluation. We didn't need to go through ethics for it, and it's been supported institutionally. And because of that, we've been really mobile and agile with it. So how have we gotten on? Well, we started off in the UK, and then very quickly, people all over the world started hearing about it. And so we then moved on and we opened up in the States. And our national coordinating center there is UPenn, and Mark Newman is our collaborator there in the States. And he's been amazing. He's been absolutely phenomenal at driving this forward in the USA. We've opened in Canada, Ireland, of course, Sweden. We're working on Italy. We've got South Africa ready and onboarded, and we've gotten results from there. We've opened up in India. So now we've opened up in about probably 15 to 16 countries globally. Australia came on board quite early as well, and we've secured the support of ANZCA as well, which is great. And we've secured, again, endorsement and support from lots of phenomenal institutions who see the value of us capturing this information. And that includes people like the ASA and the Karolinska Institute. So it's been a really amazing experience how quickly we've managed to open in all these countries. Of course, we can't quite open without getting the approvals locally. So the only holdup really has been making sure that there is some form of approval going locally.
Yeah.
The one thing I'm really excited about is Latin America, because we're hoping to open up in Latin America to about 21 countries in the next couple of days as well. Wow. So that's going to be a really exciting one.
So already a truly global project. What kind of numbers are you hoping to achieve in terms of records? I mean, is there a number at which you're going to stop, or how are you going to go forward with this project in terms of an end date, really?
Yeah, it's a really great question, and one that we ask all the time.
Because coronavirus isn't going away anytime soon, unfortunately. So
exactly, and that's the problem that we're facing. And so what we've got 3,800 intubations or so that we've registered. We have all that information of nearly 4,000 intubations globally. Wow. And that also tells us things about how often they convert to ePhona and that these intubations are actually much higher risk than any other intubation that we've ever done before. Okay, we've got that information now.
Wow.
So we've got nearly 4,000 intubations registered. We have follow-ups from 1,500 people. So remember, each intubation can be associated with multiple operators, because it could be my assistant that registers on Intubate COVID as well. Mm-hmm. But also, each person can register multiple intubations. So we've got about 1,500 responses for our outcomes, which is really, really great. But we want to work harder on getting as many responses as we can for that outcome data. When do we stop? Well, we think what we're probably going to do is we're going to be publishing reports as we go along. The reason this is important is we think that this is much more important for us to do than one big publication or whatever. And people need this information. People need to know. I need to know it quick. And as with everything coronavirus related, everything happens super quick, right? Like breakneck speed of information dissemination. So we're actually publishing reports live all the time on the website. We're tweeting information all the time. So the only thing that we're not doing is not doing statistical analyses and publishing that yet, because we don't think we're in a position yet to do that. We have a great team of statisticians from the London School of Hygiene and Tropical Medicine. Professor Stuart Pocock and John Carlisle is going to be doing the stats for us as well. And we think that if COVID continues, which we think there's probably going to be a second peak soon, we need to be continuing to capture this information.
Reflecting the crisis itself, this project will be dynamic in terms of when you think it will be completed. It just has to adapt to the current situation that we face.
I think the most important thing really is the information and the data that we're collecting is the user's information and data, and it's important for everyone to have access to that information as quickly as possible. So we're doing what we can to be as transparent and open and give people that information to change their practice if needed.
And intubation airway management is obviously not the only aerosol generating procedure. Do you have any thoughts of expanding the project to encompass other procedures exposed to other healthcare professionals? Is that something you've considered?
With time, it'll become a different type of procedure that we're going to be looking at. So certainly we're now looking at tracheostomies, which are increasingly building up, as I mentioned before. Individual aerosol generating procedures is hard to capture. Now, there's a reason for that. So ENT specialists in particular, so their nasal endoscopies and things like that, they've effectively pretty much ceased doing them now. But as the pandemic slows down, then they may start doing that. Things like bronchoscopy and things like suctioning that critical care teams do, they are significant aerosol generating procedures. But the problem is they're doing it so often, as well as other procedures. So there's too many confounders there.
Yeah.
We are working on expanding, though. We are looking and working on a global survey of healthcare professionals. And we're pretty much there, hoping to launch in the next couple of weeks. It's called Healthcare COVID. And we're trying to capture as much information from as many healthcare providers as possible. So not just anaesthetists and not just doctors and not just people in hospital, but GPs as well, you know. OBS COVID is now on board, and I don't know if you've heard about that.
No.
So we've started OBS COVID as well. And that's a new project with Sam Bampo, Pete Odor, and Nuala Lucas that we've been working on. So we're looking at the risk of conversions and exposures in the obstetric setting, either isolated episodes or background exposure in the OBS setting.
In terms of your conclusions that you hope to gain from the project, do you think you'll be able to get definitive conclusions, that you'll be able to kind of sift the signal from the noise? Or do you think your objective is that this will guide further projects or guidelines that will hope to change practice? Or do you think this project itself will be able to change the way we manage ourselves during these kind of pandemics?
We know that this is all going to be demonstrating association.
Right.
So we are not going to be able to demonstrate causality.
Yeah.
And to do that, you're going to need well-designed randomized control trials, which is probably going to be quite hard for us to do, to conduct a randomized control trial in this sort of setting. I don't know if we would ever get ethics for it. Mm-hmm. So what we think is we're probably going to be reporting the association, and not saying definitively that A causes B, but just saying and suggesting, really, I think, that A is associated with an increased risk of B. That's effectively what we think we're going to be doing. But I don't think that this is the be-all and end-all. I don't think that a single study is sufficient to draw final conclusions. And I think that the way that this virus and this pandemic is moving, we will need more data and we will need more evidence from people to support different aspects of what we're finding as well.
Kariem, as I say, fabulous work. We must leave it there. But again, I thank you for all your efforts on this very important and personal project, really.
The other thing I also just want to highlight is that this project was a real team effort. It's not my project. It's all of our project. And none of us would have been able to succeed if we didn't work together as a team. And I'm blessed to be able to work with Imran Ahmed, another consultant, colleague of mine at 2000 Companies, who is just brilliant, and Danny Wong, who's been phenomenal and is a tech genius as well. And we've had Craig Johnston helping us on the tech side as well. So we have an amazing team, and this was a real team effort, and each one of us had our own roles in the project. So none of it would have happened if we didn't come together and work together as a team and have WhatsApp tests from messaging each other 100 times a day about the project. So I think everyone needs to recognize that nothing moves forward without a group of you together.
And we urge everyone listening to join the effort, because as you've heard, the more data we can get, the better position we'll be in to protect ourselves going forward. So register now, go to Intubate COVID and get your details up there. Thank you for listening. You can hear more of the podcast on the Top Med Talk website. But for now, that's it from me. And again, thank you, Kariem.
Thanks very much for having me.
Top Med Talk. Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.